Hello, I'm Allison, and today I'll be discussing a CNS-led implementation of manual prone positioning in a community hospital ICU during the COVID-19 pandemic. So I'll be describing some of the significant benefits of prone positioning for patients with acute respiratory distress syndrome, as well as going over a rapid implementation of this therapy in a community ICU during the very start of the pandemic. And then I'll incorporate some of how the role of the CNS can really help to improve patient outcomes and cost savings when implementing a project like this one. I do not have any disclosures. So to set the setting, I'm from IU Health West Hospital, where I'm a clinical nurse specialist there. I cover both our intensive care units and progressive care units. We are located in Avon, Indiana, and part of a large comprehensive healthcare system of Indiana University Health. West Hospital has currently 127 beds, although we have just expanded over the last year and a half and added an additional 48 inpatient beds. But you can see our numbers for the volumes that we have in our emergency department and inpatient admissions, as well as the service lines we cover. We are a magnet recognized hospital as well as a primary stroke center. So for a little background of this project, prone positioning has been a recommended treatment for moderate to severe ARDS for several years now. It's been a recommendation from for the guidelines for treatment of ARDS, as well as most recently recommendations set out by the Society of Critical Care Medicine for treatment of patients with COVID-19 and moderate to severe ARDS. More recently, there have been studies that have shown a reduce in mortality with the early initiation of prone therapy when you're proning for greater than 12 hours a day. Now, there are several different techniques, different devices, and different beds to help assist staff in turning the patient prone. So why is this significant at West? Well, prior to March of 2020, our ICU had experienced very low volumes of patients needing prone positioning. And in fact, we've only used the prone kinetic therapy bed for about 3 times in 2019. Now, going into the pandemic and with kind of news of what COVID-19 would look like and how patients had been progressing to ARDS, we knew that this is something that we needed to look into because the supply of these prone kinetic therapy beds was probably not going to meet the demand. And in fact, in previous years, such as when H1N1 came out, we did have delays of upwards of a week just to receive the beds. The beds aren't something that we own, but a rental bed, and so that is shared. That demand is really shared across the central Indiana. And in particular for our ICU, previously in the beginning of 2020, we were 8-bed ICU, and over the course of really a couple weeks in March, we had to expand to a 32-bed ICU. And with that, like many hospitals, because of the increased demand, we also had to somehow manage our staffing. So we went to a team nursing model and brought in a lot of support staff that weren't necessarily familiar or had experience with the ICU patient. So the beginning of March, this was really one of our priorities for our ICU was how do we implement manually prone positioning, knowing that our supply of automatic beds was just probably not going to reach our demand. So quickly really went to the literature, pulled out guidelines, knowing that this was a recommendation, but really tried to figure out where we could find different protocols or criteria for proning. So really developed that based on what we found around the definition for moderate to severe ARDS, focusing in on that PF ratio, and then went to look at, okay, how do we best prepare our nursing and respiratory staff to prone position these patients. So developed a checklist when they would go into the room to to prone that patient so that they could both safely prone the patient and mitigate the risk of pressure injuries and tube and line dislodgements, while also protecting their staff from injuries as well, from repositioning the patient. So as you can see, there's just a real snapshot of some of our criteria and the first half of our checklist as well. So once we had that developed and really looked at different techniques, prior to really the spring of 2020, there wasn't a whole lot out there as far as different techniques in prone positioning. Obviously, that literature grown immensely over the last year. So we did a lot of rapid experiments to see, okay, based on the equipment and the beds that we had, what techniques would work best to help to get the patient in the right position, as well as preventing pressure injuries, airway obstruction, and tube and line dislodgements. So after we had kind of what our technique was going to work best for us and our staff and our patients, really went to the bedside and did a lot of hands-on coaching by myself. Anytime we did it first with the mannequins when we had some extra beds, and then once we filled up, it was helping the staff get comfortable and familiar with that technique. And since we had that team model, really honing in on that primary ICU nurse and coaching him or her, and then so that they could then in turn coach the rest of the support staff. And then to continuously look for kind of improvements and to help collaborate and focus on that patient's plan of care, we did huddle daily with the primary nurse, the respiratory therapist, the intensivist, and myself to really coordinate that care. Prior to COVID, we were doing daily multidisciplinary rounds. That just really had to hone in and become a little more succinct when we had so many more patients. So to go along with this, we also did, thanks to my CNS education and RT colleagues, did a quick little video as a quick reference for the nursing and RT staff to review quickly. Obviously, we had the checklist and the steps written out, the procedure steps written out step by step, but this was just a fun little way to grab their attention and really be able to quickly reference how to prone position.
Turn around, don't watch me now, just turn around. Touch your knees, don't look, just turn around. Do it now, you make me count to 4. 1, 2, 3, turn around. Watch yourself, why don't you turn around? Can't you see I don't need you around? Do it now, walk right through that door. Who could it be? Don't look at me so obviously. It makes me sweat straight to my head. I'm turning red, touch so unsaid, so I'm all set. And step outside, just hit me high. Before I forget. 1, 2, 3, turn around. Don't you watch me now, just turn around. Touch your knees, don't look, just turn around. Do it now, you make me count to 4. 1, 2, 3, turn around. Watch yourself, why don't you turn around? Can't you see I don't need you around? Do it.
So as you can see, it's a quick little video that describes our technique, and they can look at those little key points right before they're going to prone a patient. Now, we've been doing it so frequently now, I don't think they need to refer to the video anymore, but it is nice to show our new staff as we onboard new staff our technique for manual proning. So now to kind of the meat and potatoes of it all, like what were our patient outcomes? So data was collected from really that second quarter of 2020, from March 1st to June 30th. And for that one quarter, we did have 55 patients who were admitted to our ICU with confirmed COVID-19 that required mechanical ventilation. Of those 55, we did manually prone 14 for an average of around 3 days. And 43% of those patients did survive to discharge. Now, what I think is really a key point and a great process outcome that we had is that we were able to initiate therapy on the day it was ordered for prone positioning. Or as you can see below, we didn't, that was quite a delay for our couple of patients that we were unable to prone position due to weight and other limitations. So we had to use that automated bed with an upwards delay of 5 to 6 days. Now those 14 patients did experience, we had 4 of them that did experience some mucosal breakdown on the lips due to their endotracheal tubes, but I'll speak to that later on how we kind of countered that. And these are just the those 14 patients marked out on their stay there and how they progressed over their hospitalization. Some things have changed, obviously. Recommendations for treatment of COVID-19. We've learned things over the last year, so we're not rapidly intubating as soon as their oxygen needs increase and using more high flow oxygenation to try to delay or prevent that intubation. But that's kind of how those first 14 that were manually proned, how they ended up. So while I discussed the patient outcomes and how we had success there, I have to really hone in too on our cost savings that we had based on because of this implementation. So of those 14 patients, they were prone for a total of 50 days just in that second quarter alone. So like I mentioned before, the automated beds we used previously are rental beds. So, and that's, upwards of $1,500 per day. So that was a savings of $76,000 just for those 3 months that we implemented manual proning. Now there were some additional costs for manually proning each patient because we do use a static overlay and a cushion for skin protection and for repositioning, but that's minimal cost of about $60 per patient. So really overall still had a direct cost savings of $75,000 in just 3 months alone. So in conclusion, I just want to reiterate our rapid implementation of manually proning really helped ensure that we could initiate this evidence-based therapy. Without it, I truly believe we would have had either significant delays in prone therapy or just the elimination of prone therapy altogether for some of these patients, just based on the amount of delays and the availability of the automated beds that we were seeing in Indiana. And with that would have had worsening patient outcomes and mortality. We do have several next steps. As we move forward with the pandemic, we are formalizing our prone positioning guidelines so that they are accessible and standardized for our ICU. We have employed other techniques to help reduce complications related to proning. For example, with the first wave of our COVID patients, we were taping our endotracheal tubes right before we proned. And with this, it was obviously in a static position for that 16 to 20 hours. And so we have changed to using a commercial device holder that we can ever so slightly move off those pressure points and reduce complications of pressure injuries that way, and have practically eliminated our mucosal breakdown injuries related to the ET tubes. We've also employed some other different prone pillows and dressings to help reduce the pressure injuries on the face. And now that we are in our new ICU, so in the fall of 2020, we moved from our 8-bed ICU to a brand new 14-bed closed unit that has overhead lift equipment. So this has opened our really the criteria for manual proning and helped to include those patients that before we probably would have said for the safety of the staff they're too large to manually prone. So using the overhead lift equipment to manually prone them to reduce staff injuries and safely put them in that position and use that therapy. We've also developed some standards for awake prone positioning for our non-intubated patients with COVID-19. I know the evidence is pretty lacking on how effective this therapy is for preventing or delaying intubation for this patient population, but it is one of those low risk, no cost interventions that we can offer to our patient population. So I've developed a lot of education and standards towards how to do that quickly, efficiently, and comfortably for the patient. So we'll see whether, as time goes by, whether that's making an impact, significant impact on delay of intubation and decreasing of oxygen needs. So I thank you for our time and for watching today. Here are my couple references I have, as well as my contact information if you have any questions. Thank you.